Hi, I'm Dustin Crovo. I'm an emergency nurse and a trauma nurse, and as well as a paramedic. I'm going to be discussing temporary definitive pleural decompressions using needle and tube thoracentesis, relief of tension pneumothorax, and relief of hemothoraxes and from chest trauma. All right, so within your pleural decompression, your indications, as many know, we're going to talk about the tension pneumothorax or pneumothorax, simple partial tension pneumothorax. You have a hemothorax with the blood accumulation. You also have a hemopneumo, which is combo. But many of our indications are just the emergency release of that tension pneumothorax. So we're going to go in and we're going to relieve that air pressure that's building up within there that's starting to collapse the lung. Some may be ineffective. If it's a simple pneumothorax, there may not be enough of that tension, that pressure building up upon the lung to actually begin to collapse it. Also, patients can have spontaneous pneumothorax. We know the tall, thin males, or maybe a weakening or a bleb on the lung can cause a simple pneumothorax. They may not need that decompression, but things we're looking for, are obvious signs and symptoms, respiratory distress, those kind of things. Also, if your patient is having a hemothorax due to gravity, all right, the blood's going to accumulate in the bottom portion of your pleural cavity, which is also going to, if you're decompressing the top portion of the chest, it's not going to relieve that. So their definitive care is going to be when we talk about the tube thoracentesis or the chest tubes. Flail segments, flail chest, that 2 or more ribs in 2 or more places that are broken. That you can't, decompressing that patient is not necessarily your first line. We want to stabilize that chest. We want to, work on their airway and their breathing and try and fix that first. So, within a tension pneumothorax, your signs and symptoms, your classic signs and symptoms, decreased or absent breath sounds on the effective side. So we're listening for those lung sounds. They're going to be decreased or absent on that portion of the lung that is beginning to collapse. All right. We're also looking for unequal chest rise and fall with their respirations. They'll also be breathing fast. They'll be tachypnic. They're going to be restless and agitated. That air hunger. They're going to look like they're struggling to breathe. So those are some of our signs and symptoms. We give us a clue that hey, we might need to be going down that route, decompressing this patient's chest. Obviously, if there's a history of a chest wall injury, or once you expose the chest, you see bruising, obvious signs and symptoms of a chest wall injury, and then you also have, decreased breath sounds, we're going for it, right? That's giving us the telltale signs. Distended neck veins, narrowing pulse pressures, indications of shock. Those are going to be some of our sign, our little triad, with your pericardial tamponade, you have Beck's triad. Well, with this, we kind of have a little triad with the JVD, the narrowing pulse pressures, and then absent breath sounds, some along those signs. So because that lung is now becoming so tight upon the heart, pressing over on the heart, creating that tamponade-like effect on the heart. And then when you have a late sign, when you're going down and you're assessing your patient, and you have a mediastinal shift, or basically a tracheal deviation, tracheal shift. And in the trauma room, we're looking for chest X-ray. You have the whole mediastinum start to shift. These are late signs. This person's, they're sick. They need treatment right away. We can needle decompress them right there in the emergency room, in the field, and they're also going to definitely be getting a chest tube. Just some different, visualization of what's happening. Your upper left corner here, you're going to have basically, your simple pneumothorax. It's not an open, there's no penetrating trauma. It could be just from blunt force trauma. Could be from, like I said before, a bleb, weakened spot on the lung, that tall, thin male that has a spontaneous pneumo. In the lower picture here, you got your open chest wound. A GSW, a gunshot in the chest, a stab, an impalement, something, some freak accident. With that's beginning to suck air into there. And when you think about a sucking chest wound, we're going to want to go down that route of first putting an occlusive dressing. That's our first step because we need to stop air from coming into that cavity. So with your occlusive dressing, like Vaseline gauze, something along that type, taping 3 sides of it, create a little one-way valve. Asherman chest seals are awesome. They work great. The Halo chest seals, if you have a commercial grade type chest seal, I would go down that route first. And then you have proximal flail segment, the upper right portion, you got the ribs broken. There may not be a breach into the pleural cavity from the rib being broken yet, but once you have that flail segment, those ribs are sharp, and they keep trying to struggle to breathe. They're going to be, breathing fast. Then you're going to have that patient, that portion of the rib puncture the lung, and then obviously you're going down, tension pneumothorax route. All right, so site selection. Many paramedics have never decompressed the chest. Just something that, it's a hit or miss. Some get, multiple decompressions per year. Others, they can go years without even ever actually physically doing one. So, site selection. Second or third intercostal space. It's going to be mid-clavicular line. Right? So right down the middle of the clavicle. An easy way you can do it is if you put your finger, your top finger on the portion of your under portion of your clavicle and reach down, about where your pinky finger is about your second intercostal space. As long as you're mid-clavicular, that's your good site, okay, for your needle decompression. Once you have that site, cleaning with aseptic technique, we want to make sure we ride across the top of the rib because your neurovascular bundle lies up underneath that rib portion, so we don't want to hit those the nerves, arteries, the veins, so we got to watch out for that neurovascular bundle, so we go top of the rib. Okay, preferably we're going with at least a 14 gauge, preferably maybe a 10 gauge. We want at least a 3-inch needle. Many are saying now 3 1/4 inch needle. Some say, whatever you got, go for it. It's, it's a life-threatening injury to this patient, so we got to try what we can. All right, and alternate sites are going to be your 5th intercostal space, mid-axillary, just anterior to the mid-axillary line. Typically, that's where you go with the chest tube. It's going to be in this axillary line here. For males, it's easy because right across from usually our nipple line. Females, it's right where the mammillary fold is, or the bottom of the breast. You can decompress with a needle there. It's not usual, but you can if you needed to. If you suspect a long transport time or hemothorax, and you're not getting relief from your, second intercostal space, decompress on that side. If you're getting a return of air or blood, let it drain. Once we do decompress this patient, we want to make sure we hear that whoosh of air. We get an air return. You can also put you can put your 3-way stopcock or some type of flapper valve. You can put a syringe on there before you decompress to kind of put a couple of mLs of saline in there, see if you get a bubble return. But we're looking for improved vital signs. We're looking for relief of that. We're looking for a better O2 stat, better respiratory rate, better heart rate, better blood pressure, those kind of things we're looking for. Improved lung sounds. Okay. All right, so again, 14 gauge or larger, superior to the rib. We want to ride across the top of that rib. We want to watch out for that neurovascular bundle. If the patient is very muscular, right, male or female, it may collapse on that catheter. They're trying to improve some, commercial grade actual decompression needles that are designed just for that to make the catheter actually more rigid so it doesn't collapse underneath the muscular wall. Again, a one-way valve. If you're decompressing a patient in the field, they're most likely getting a chest tube in the ER or in the trauma room. So considering chest tubes, if it's within your protocol and you are trained to do chest tubes, by all means, drop a chest tube in. We want to make sure, obviously, we secure it really well. Bulky dressings, lots of tape. We don't want it to get removed. We don't want it to pull out. Sometimes it may not relieve completely, or again, it may collapse on itself, and you may end up having to decompress that patient again. So just think about those kind of things. Once you go into that procedure, you want to make sure that you think a few steps ahead of, hey, what could happen? Then altitude changes. Okay, so if you're flying, those are some of the things you want to consider. Relieving the pressure on that. If you have a 3-way stopcock, obviously you want to open it up, let some air out. When you're up in altitude, obviously that increases, so you're gonna have to relieve that pressure more often. All right, just picture some commercial type things. This is a commercial smaller chest tube that they use sometimes, and then sometimes they use this filter if they're actually returning a lot of blood from it. They actually can auto transfuse back their own blood. All right, chest tubes are definitive treatment. So this is whether you're within your protocol to do this in the field or whether you're in the trauma room. So indications purpose, obviously, now we're looking at one, relieving tension in pneumothorax, but two, now we're thinking any type of fluid that we need to drain. Sometimes you're talking infections, empyema, things like that. So we want to look at what we're treating this patient for and why we're doing this chest tube. Obviously, in trauma scenario, we're talking blood and tension pneumothorax, hemothorax, hemopneumo, and then obviously they're larger. Anywhere from like a 28 French all the way up to like a 36 French. These are large tubes, so they can drain large amounts of fluid. And many of the commercial pleurovacs that they have now, you can actually collect their blood and auto-transfuse these patients back their own blood as you're doing trauma resuscitation if they're actually bleeding that much. Otherwise, you're just collecting. And so we'll talk more about the actual chest tubes themselves. Just a good chest x-ray itself, you can actually see the large mediastinal shift here. You can see the heart portion here. You can see the inferior vena cava, the trachea is all shifted, all deviated over. You see the large void over there where the lungs actually collapsed and pushed over on the heart. All right. So with chest tube insertion, more of a sterile technique, unless this is something that's pre-hospital, and then you do as sterile as possible, aseptic as possible. But it's that fifth intercostal space, mid-axillary line. Some go anterior, just depending on what's going on. If you're going to go the second intercostal space on the anterior portion of your chest, they're looking at smaller tubes, and they're also looking at it's more of an air issue than it is a fluid issue, or they're not looking at much fluid being drained. But the classic site, fifth intercostal space, mid-axillary line. Once they're going to start this, we're going to have to also take consideration, is this patient conscious? If they are conscious, it's a very painful procedure. So you want to get the lidocaine, you're going to numb up that area. So once we get all our equipment set up, tubes been chosen, you got your Kelly forceps, you're going to make about a 1-inch incision. At 1-inch incision, 2.5 centimeters or so. Once that's been done, basically they're going to go in with their finger. They're going to kind of create a pocket, trying to get through the fascia. They're also going to have their Kelly forceps, and they're going to make sure they get through into the pleural cavity. So they have to get through that parietal pleura. So you're in between the visceral pleura and the parietal pleura and the pleural cavity. And classic with these is once you start inserting the chest tube, you're also making a decision whether you're thinking, is this more of an air issue or is this more of a fluid issue? Fluid issue, you're going to aim this down inside the pleural cavity. So they're actually going in with their finger and they're aiming it down in the pleural cavity. If it's more of an air issue, they're going to try and aim it up. And so, because again, due to gravity, air is going to accumulate at the top, fluid is going to accumulate at the bottom. So we make sure we remember those kind of things once we're inserting this tube. It's sutured in place and it's sutured tight. You don't want this pulled out. Painful procedure 1 and 2. Once you cut that chest open, you create a sucking chest wound if there's not already a hole in the chest. Stabilize with bulky dressings and tape. Once it's there, it's good. You're going to monitor this patient. You're going to monitor drainage. You're going to monitor their respiratory effort, rate, depth, quality. You want to make sure you're watching their entitled CO2, watching their O2 saturation. And again, this is probably going to be hooked up to a commercial grade pleurovac. With that, with or without suction, depends on what is ordered for that patient. Most I've ever done, most I've ever seen, they're typically on some type of suction, even if it's low suction, because the pleurovac itself is so advanced it actually regulates the suction itself. So anywhere from like -10 to -20 centimeters of water for the suction is already regulated within that, and it's on the water seal. All right. So a good example of a commercial grade pleurovac. It also has the water seal in it. A lot of them come with pre-filled syringe. All you do is pop it off the back, you fill it up, it creates the water seal. Within that, you can have intermittent bubbling, which is okay. With respirations, if you see intermittent bubbling, that's how it's supposed to be. If you see a continuous bubbling in any pleurovac, whether you are transporting a patient that already has a chest tube in place, or whether you are actually placing the chest tube yourself. We want to make sure we don't see a continuous bubble, because that means we have some type of leak in the tube, leak in the system. Something's not right. Maybe the tube even actually got pulled. So make sure we're continuously monitoring that. Intermittent bubbling is okay. Watch your collection. Right? We're looking for blood. We're looking for, if you start to begin to see pus, if it's already an established chest tube, maybe some type of infection occurring. Check the site. You're taking somebody, at some type of facility. We want to make sure we inspect our site, inspect how much fluid has already drained. That way we can document all this. If there's an increase in drainage due to flight, so on and so forth. Flag or ground transportation. All right, so again, quality amount, color changes, blood, pus. You need to maintain a dependent loop in the actual tube that connects to the patient. We don't ever want that tube to get above the patient, because you're going to return air and blood back to the patient. All right, so an example, this is kind of the old school method you used to do bottles for a water seal. And then just an example of comparing the two. This is actually return from the patient, accumulating the blood, your little water seal here to suction. Just examples of what Pleurovacs, what they are, what they do. All right. Complications of chest tubes, recurrent pneumothoraces. Some patients, if they have a chest tube in place and they continually, they can't get this patient to heal. They actually go in and do this procedures like pleurodesis. It's kind of, they actually infuse this medication that actually seals the lining of the parietal pleura and the visceral pleura to each other. It's almost like they glue it together. So it actually creates like a seal in the lung, so these patients can actually begin to heal. But that's, complications down the road, not much that we typically would deal with. Watch for accidental removal. We never reinsert a tube. You just treat it like a sunken chest wound, place a occlusive dressing over it, and then we're going to basically go back to our airway and breathing, make sure they're okay. If we have to ventilate the patient, we do. If we have to intubate the patient, we do. But basically, if a tube gets pulled, create it like a sucking chest wound, and start from there. And if need be, you can always divert to the most definitive hospital, closest facility, if it's a really bad patient going downhill. If the Pleurovac itself breaks, most likely, hopefully, you have an extra or bring an extra, just in the case of this, for some reason it breaks, loss of suction, things like that. If you do lose something, if you do actually break the collection chamber, you can always take the tube and place it in a sterile saline in the bottle, our big bottles of sterile saline. That way you create a water seal, so you're not returning any air or blood back to the patient. Once you get your new collection chamber, new Pleurovac set up, and just reattach, hook back up the suction, reassess, everything should be good. Okay, this is my presentation on temporary needle decompression, temporary needle and chest tube thoracentesis, decompression of patient chest due to tension pneumothorax, hemothorax. Thank you for your time, and have a great day.